revascularization. Now, let's talk briefly about the SYNTEX trial. I won't show you the design of the SYNTEX trial because you've heard a lot about it. I won't talk about the SYNTEX score. However, let's look at the major adverse event rate at 12 months in a SYNTEX trial. Death, MI, no major difference in all patients. The stroke rate was significantly lower in favor of PCI in comparison to bypass surgery. However, the repeat revascularization was high, and because of the repeat revascularization, the overall MACE event rate was high. And this is MACCE, not MACE, which includes your cerebrovascular events. Now, if you carefully analyze the SYNTEX data, and always the detail is in the devil, and this is why you have to read the paper, not take the sound bites. Look at the diabetic, non-diabetic group, and look at the diabetic group, and look at the SYNTEX score. The patient that Dr. Shah showed you would clearly have a SYNTEX score of more than 30. That patient we would not recommend PCI procedure for. This is a patient who is going to have a mortality benefit with bypass surgery. And I will share with you some reasons why I think that is. If you look at the SYNTEX score in diabetic patients, even greater difference. However, in the low SYNTEX tertials, with a SYNTEX score of 0 to 22 and 23 to 32, no difference. This is exactly why I told you that not a referral doctor should make a decision, not a bypass surgeon should make a decision. The decision should always be based on angiographic interpretation of an experienced interventional cardiologist who wants to do best thing for the patient. So they really have to look at this data very carefully and make a decision for the patient. Now, if you look at the revascularization rate, again, in diabetes, patients with high SYNTEX tertial score, they had higher revascularization rate, all comers. But if you look at the lower SYNTEX tertial score in non-diabetics, no difference. Now, this diabetes story needs to be understood a little bit further, and which is very important. If you look at the non-diabetic versus medically treated diabetes, but if you separate them out further, patients, those who were on just oral hypoglycemic therapies, there was no difference in all-cause mortality. The difference is only realized when there is a problem with the insulin-dependent diabetes and higher SYNTEX tertial scores. I will skip some of that. So, in general, if you treat 100 patients with CABG instead of PCI in the most complex and high-risk patients ever studied, you save 8 PCI in target lesion revascularization rate, but you gain 2 strokes. So, it's just a good deal for your patient. As I said earlier about the operator and institutional variability, this is the SYNTEX trial. You can see this is Texas stent MACE rate. There are centers which is very high MACE rate with post-stenting, and there are centers which is very high MACE rate with the CABG surgery. So not every institution does the same PCI procedure, not every institution does the same CABG procedure. Cost, I won't go into cost because the cost factor is greatly different between United States and India because the financial system works differently with the third-party payers. The PCI procedure is actually cheaper than bypass surgery in US. Now, let me give you a final thought before I end this session. Is how do you do a PCI these days? We do angiographic PCI, and look at this angiographic data versus look at this fractional flow reserve guided, which is ischemia guided intervention. In FAME trial, multivessel disease patients, PCI angiographic group and a PCI FFR group, again, if you look at the overall MACE event rate, is even lower than the lower tertial of the SYNTEX trial. So patients in the FAME were very similar to a low SYNTEX tertial group in multivessel disease. So FFR guided PCI also improves. So in summary, PCI is preferred in most PCI eligible patients with multivessel disease as long-term data with stent demonstrates similar rates of death and myocardial infarction compared to bypass surgery. Patients with diffuse multivessel disease and insulin requirement patients are probably best suited for bypass surgery. Ultimately, there is no alternative to a good clinical and angiographic judgment of an experienced interventionalist and decision making between PCI and CABG. Thank you very much. I hope this was helpful.
And low cost. It is hardly costing anything and very good compliance and adherence rate. You'll be surprised to know, ladies and gentlemen, your own organizing chairman is consuming a polypill. And ladies and gentlemen, the speaker also is consuming a polypill. The TIPS trial is shown very clearly realize the dream of heart risk protection. The teaching is blood pressure reduction is good, aspirin effectivity is maintained, is very well tolerated, effective and safe. Accept polypill and embark the outcome trials today, Professor Cannon said from Massachusetts in ACC. Professor Cannon also said, enough is enough. Time to reflect is now. Adherence and compliance benefit should be practiced now in reality. Effective dose benefits should be known to everyone. Plan CVD outcome trials before it is too late. Plan for mass consumption for heart attack eradication program in less than 70 years of age. The data which we published in Indian Heart Journal just few months ago have shown very clearly that 3D echocardiography is the most powerful predictor of occult CVD and diastolic heart failure. And I personally feel polypill is going to be a great asset. And we are conducting a trial very soon, which I'm going to show you next slides. These are the ongoing trials which are known to you: TIPS trial, IMPACT trial, Red Heart Pill pilot trial, Indian study and Spanish study. My worthy opponent, I don't know with whom he is going to fight. He is going to fight with himself. There is no fight so far as polypill is concerned. It's very well accepted. It has to be only practiced. It is the outcome trials which have to be practiced. My worthy opponent, I came prepared for the fight, may say not many randomized trial data. Here is the time. Plan for the randomized trials. We already have one to show us the trend. No data on added side effects. It's very well shown in the TIPS trial. No data on drug interaction shown in the TIPS trial. Long-term outcome, we have to plan. Nobody else will plan for us. Mortality and morbidity benefit data has to be presented. The polypill is as effective as an individual component with no side effects and is very well tolerated. Ladies and gentlemen, these are not my words. These are the words in Lancet. Polypill is a magic bullet and a blockbuster. Please understand the application and the practicality of usement. For my muddy component, do not confuse and not to be in fear of using polypill and crystallize the solution today to plan for more studies. Ladies and gentlemen, polypill package has simplicity, ease to use, low cost, many medical consultations, no pill load, no memory load, no pill load, an effective prescription and not 1.25 milligrams of Ramipril or 5 milligrams of atorvastatin, and event-free survival of 11 years with defer need of PCI or CABG. And I think we have to be selective. I agree with my opponent. There is no dispute on that. This is a very important statement by Dr. Steven Nissen from Cleveland Clinic. He said and asked a question in ACC, is polypill for developed or developing countries? He thought it is coming from developing countries, so he asked this question. The answer given by Yusuf Salim, it is for sensible people. If you are sensible, you know where to use, when to use and how to use and for how long to use. Dr. Smith from North Carolina, his statement at the same time in a commentary, he said, BP reduction definitely matters by polypill, but outcome trial will matter more. So now is the time to plan for the outcome trials. This is the nutshell. I am giving a project which we are undertaking in our hospital, a 3D echo for occult CVD and metabolic syndrome. We are measuring LV remodeling, carotid intimal media thickness, LV diastolic dysfunction and LV MPI in all the patients before polypill and 6 months after polypill. Maybe in 1 year's time, we'll publish the data, positive or negative. Challenges for this trial: protocol for mass consumption, safety profile, individualizing our patients, and of course, we have to take into consideration the liver functions and the kidney functions. To conclude, ladies and gentlemen, everybody in India is at risk for CVD after 50. Dr. Kyor Parikh was telling me his age 52. I am 59. Everybody needs it. We have to understand, those who take it, they don't suffer from the events. Aspirin, beta blockers, ACE inhibitors and statins have a morbidity and mortality benefit. Heart protective pill is the most powerful intervention to reduce heart attack and brain attack known to the mankind from the inception. CBP polypill is the need of the hour. Time to plan outcome trials today before it is too late. What's the take-home message? Health of millions is at stake with CVD in India. Heart protective pill has a tremendous risk reduction potential. The benefit outweighs the disadvantages. First polypill data, TIPS trial has shown us the promise. Large outcome trials are need of the hour. Enough is enough. We should act now. We should act locally and impact globally as we created in the last ACC. Time to reflect is now before it is too late. CBP polypill, as spoken by Professor Cannon, has obvious appeal and vast implication for CVD protection, not only locally but globally. Professor Cannon has also mentioned, realize the dream of heart attack eradication program and brain attack eradication program between 30s and 70s. Death is inevitable. We all know it. Everybody is to die. Polypill, the only hope for the future, event-free survival for 11 years after 55, work better with lifestyle optimization. Polypill is not a substitute for lifestyle. We have to have both. Polypill is a CVD blockbuster. The man behind is Professor Nicholas. Dream, heart attack free society less than 70. We should not become a victim of polypharmacy, a real role model on heart protection. Thank you very much for a patient hearing. I am very happy for your attention.